Hello, good morning, everyone. Thank you so much for joining our SPSP Perinatal and Paediatric Programme Webinar. I'm absolutely delighted to welcome you all here this morning. We've got a fantastic lineup of speakers planned for the next hour and a half, and I'm really grateful to everyone for taking the time to join us, because I realise how busy teams are. Next slide. So the topic of this webinar this morning is around engaging seldom heard groups in perinatal and paediatric services. I'm Sonia Joseph. I'm a consultant paediatrician and a clinical director in Edinburgh and NHS Lothian for medical paediatric specialties, and I am the Scottish National Strategic Lead for Children's Health. So it's an absolute pleasure to see you all. I'm hoping that everyone can hear and see me okay. I've been told by the team that everything's been working, so it's great. So we're just going to move on to the next one. Welcome everyone for using the chat. Next slide. So just a few little pieces of housekeeping. So whilst we've got the presenters speaking, the cameras and mics will be turned off, but these will be enabled for the question and answer session at the end of the webinar. Next slide. So if you want to share any thoughts, and I would really appreciate it if you did, some people have already started from what I can see, but please do so by using the chat functionality. We're going to be running a poll this morning and using the chat actively, which will be monitored by members of our team to enable engagement across all the teams. And I'm really pleased with the registration list. We've got representation from across all the boards, and once again I recognise how busy everyone is, but it shows the commitment to the care we want to deliver our patients that so many of you have taken time to join us this morning. We will be having people monitoring the chat for any questions for the Q&A later, and then if anyone feels brave enough to put their hand up and then ask a question, then that would be great as well at the right time. Next slide. So this session is being recorded. This will enable our colleagues who couldn't join this morning in order to watch the recording. And it's also a great chance for your own CPD. So certainly for my own appraisal, what I do is I take the link from the SPSP website, put it into my reflective diary, and then write a few sentences around what I learned, and I use it as a kind of trigger to think about my learning. So it's something that is a suggestion for you all, and it's something out there, and it's certainly valued by many of our colleagues. Next slide. We've got the agenda that you can see there, and as I've said, we've got a fantastic list of speakers from Greater Glasgow Clyde and Ayrshire and Arran. And I'm absolutely delighted that people have taken the time to join us this morning. We will aim to finish by 12, and as you can see, the most vital section at the bottom is next steps, closing remarks, and your feedback. So I know that you're all busy, but if you've taken the time to join us now, it'd be really great if you could stay for the full session. And if you can't manage, and if you've got any feedback for us, please pop it into the chat, and our team will get back to you. We've got our fantastic improvement teams on the call, so if anyone needs some support, then and with your cameras, mics, any technical difficulties, please email the HIS email, which is his.spspp@nhs.scot, and the team are monitoring that. We've got our fantastic improvement team on the call as well. So we've got Tim and Damien, who are improvement advisors, and Joe Thompson, who's our senior improvement advisor, as well as Dagmar and Elaine from our brilliant project support team. So they're all here to support our call and our time together this morning. Next slide. So what are the aims of this webinar? And I'm going to speak honestly, as a general paediatrician who did a very full and intensive acute week last week, there are children that go through the unit that I wish I could just take the time to listen, or there was somebody there who could take the time, because people will never tell the person that could potentially have the needle in their hand the truth about their experience, or because they want to say it all went well in the end. But there are definitely things that I'm sure we could do better, but sometimes the totality of the problem feels so enormous, it feels beyond your grasp. But the aim of this morning is to connect our population with some excellent individuals who are working currently in 2 boards who have done exactly that, engage seldom heard groups in perinatal and paediatric services. The examples we give you are real tenable examples. They'll give us our lessons learnt, and these are all things that we can all take away. And it's also a fantastic opportunity for networking and question and answers. And if you put a question in your chat, in the chat, that we don't get to, or you think of something later, then please use the email to get back in touch with the teams. If you're rushing and you just want something answered but you can't stay, then please put it in the chat for this webinar, and our team will do our best to collate these and get back to you. Next slide. So to put it into context, we've had a number of learning sessions which have spanned a range of topics, so including children and families and co-design of improvement work with paediatric breakout slides in March 24. There's the SPSP Paediatric webinars that we've undertaken with worry and concerns, which have had a focus on parental and carer and patient concerns in June 24, and the perinatal programme SPSP webinar on racialised health inequalities in perinatal services in August 24. And I hope this shows an active intention to highlight and to connect our populations of colleagues who deliver care across multiple healthcare settings in Scotland with individuals who have done the work or have started the work and are progressing it, who are there to connect us all to their lessons, what they've tried, so that we can then learn from these systems and then apply them to our local context. It's all out there. It's all on our SPSP website, which we'll put links to at the end. And then this webinar, once it's been curated, will also join the resources section on our website. So please feel free to share the links with your colleagues who couldn't attend this webinar. Next slide. So if we think about our person-centred care driver diagram, we've got, as part of our driver diagram, we've got all of us actively try to deliver person-centred care. I fully acknowledge, as an acute paediatrician, there are many times where the sheer demand and the volume of work means that sometimes you walk away thinking, actually, I wish I could have done that better, or I wish I could reverse that, or actually there are 6 children with this presentation, 3 mums saying this to me. You know, those are all connected, and how do I make this better across the whole system so I'm not hearing this thing again and again? If we look at the secondary drivers that are linked to our person-centred care driver, you've got patients and families, carers listened to. Again, that's why we hosted those webinars and started those resources. So it's tools that are actively there to help your teams. Thinking about anticipatory care planning, looking at inclusive care pathways, which provide equitable and culturally appropriate access and treatment. And our speakers today certainly have experience of this. There's discussions with families are well managed. And again, those are all things that we want to do and that we can do. But it's how do we then allow the system around us to learn from that, so it improves for every family each time. Looking at women and birthing people are listened to and included in their care decisions, and then that person-centred care planning. So those are snapshots from our overall driver diagram for our improvement programmes. Next slide. First of our speakers, the first group, which is from NHS Greater Glasgow Clyde, talking about their maternity engagement work on hearing seldom heard groups in perinatal and paediatric care. I'm absolutely delighted we've got Mary Ross-Davie, who's the Director of Midwifery in Greater Glasgow Clyde. She joined the team in June 2022 after having an extensive career in midwifery across multiple settings, including support for mothers who are HIV positive and addicted, have a problems with addictions, in addition with problems with mental health difficulties. And I'm also delighted to have Paul Hayes, who's lead in public engagement and public involvement for Greater Glasgow and Clyde. He has a background with engaging members of the public across, initially in citizens' advice, across multiple different sectors of our population. And I'm absolutely delighted to welcome them to this webinar today. Over to you guys. Thank you.
Thanks so much. Thanks, Sonia, for that great introduction, and thanks for the team for inviting us here today. I'm actually sitting here feeling quite humbled because all of the comments in the surveys just show how far ahead so many services are and all of the work that you're already doing out there. So I don't think we're going to share with you today everything that you haven't heard of before at all. I think it's safe to say that the NHS Greater Glasgow and Clyde were a bit late to this party. So the Best Start review recommended that there should be active MVPs in all boards and that there should be really rigorous engagement with women and families with maternity services. And we hadn't really got to that. So when I came into post in 2022, what was great to discover is that we had a public engagement and involvement team and an equalities team who were really keen to get going. And so once we brought in the maternity focus on this piece of work, then we could really hit the ground running. I'm actually going to hand to Paul for the majority of the presentation. It's very much been multidisciplinary team working on all of the work that we've been doing over the last 2 years. What I did want to point out is that we've made the decision locally in GGC that we will generally use the word women when we're talking about our service users, because the great majority of the people in our care do define as women, but we do also acknowledge that there are some maternity service users who don't define as women, and we would always respect that and the words that they would like to be used to describe them. So we've taken what's called a partial additive approach. So generally we'll say women, and then on occasion we'll also use other terms like birthing people. So we've taken our steer from the RCM and the RCOG on that. So just to give you that background. And I'll now hand over to Paul to begin to talk you through our work.
Thanks, Mary. And hi, everyone. If you could move it on to the next slide. Yeah, there we go. Yeah, so in Greater Glasgow and Clyde, as Mary said, we've looked at a range of different ways to listen to what women accessing our services are experiencing, what they're telling us, and how that can lead to improvements, with a view of how we can then bring them together in more formal processes. Started with this slide just to kind of show there's a bit of a spread across the board and our different sites delivering maternity care around the percentage makeup of our population, with the Princess Royal, the Queen Elizabeth having the largest Black minority ethnic populations in the board. Really important for us to take an improvement focus around about this, to look at how we can capture the views of women, families, and how they can feed into the wider maternity developments and improvements across the health board. But with that view, well, we need to work to understand particular experiences in particular hospital sites or areas of the board as well. If you just move us on, next slide. Yep. Big bit for us has been partnership and how we work together with our third sector colleagues across Greater Glasgow and Clyde. There's been a number of initiatives, a number of pieces of work over the years, led with maternity and with the Equality Human Rights team and our third sector partners to listen and learn from each other. A big driver off the back of some of our more recent engagement surveys and engagement work that we've done with women was to enhance this group and expand it and bring more third sector partners together, and directly link them up with midwives, with specific projects within midwifery, such as our Blossom team or bereavement services and feeding teams, to learn about developments, learn about new ways of working, and then but also listen and hear about any issues possibly been faced, and for that to trigger thoughts of different ways of working and different ways of collaborating. A big thing for us has been about this being owned by everyone. So it's not our group, it's a group that is in partnership with the third sector. So the next session, first session was hosted by us in in the Princess Royal, an opportunity to show off some of the space and some of the developments around the birthing suites and how that's evolved with in partnership with women, and their feedback shaped the developments and improvements of that space. But future ones we're looking at meeting in third sector spaces to bring midwives to them, and also to bring different third sector groups together to learn a little bit more about each other as well. And we'll co-design that agenda. So really important for us from that perspective. And if we move on to the next slide, that's a big part in how we're shaping care with women, to take the same sort of approach. We've launched our Maternity Voices Partnership with the next second meeting due this month of it. And again, that's very much a distinct space for women with experience of the service. And that was a decision through some conversation with midwives, from taking consideration of feedback we'd received from women, third sector, from everyone, around giving distinct spaces so that there are that different voices had different space to kind of breathe a little bit and to talk about issues that were important to them. And certainly there's crossover there, but it's just to make sure that there's a defined space. Initially, we talked around how we can enhance communication going forward, looking at how we improve continuity of care, reflecting back on some of the work we've done in recent years to understand the experiences of people in relation to continuity, how those voices have led to change and reassured us that change has been going in the right direction and that improvements and have been working for women, and that it's not just something that's working for maternity services. It's also helped us conversations between maternity third sector groups and MVP groups with staff who've attended both, has really helped us shape what our twice a year surveys are looking like. Initial ones looked at continuity, as I said, then we looked at travel and how to get to care, and currently we're just about to launch our next one, and that's really going to focus on visiting, understanding that, along with mental health and well-being and what that looks like for women. If you just move us on to the next bit, speaking of the survey, that was a big change for us, and it was a big game changer in many ways, because that let us reach out to everyone who had given birth in GGC. Not that I would advocate doing that again. That was an awful lot of data to start with. I think we got a much higher response rate than we thought we would, about 23-24% from memory. But we reached out to 13,000 people who'd given birth and got 2,900 responses. We've had 5,000 all in over the work that we've been doing, and that's included face-to-face, smaller community-focused pieces, interviews at clinics to understand experiences, as well as this larger digital bit. So it's not by any means we're just doing digital. It's acknowledging that's a really great resource to get a lot of feedback, but it's not the only way. So we did this initially by co-producing with maternity colleagues. The idea is to co-produce it much more in partnership with maternity, third sector, women's views, and use our MVPs, third sector groups, to understand issues that we would like to talk about in more detail for the next set ahead. And then we use a mix of web report and MS Forms. That's just down to languages and what languages they work with best. Use BadgerNet to identify top languages and to identify contact information, and then sent messages out in the language to languages that are preferred by different groups of women. That was really powerful. It gave us a lot of really powerful insights. Like I said, the initial piece was on continuity, subsequent piece on travel and access to our sites and what that looked like. And the learning from this has been really useful. We're now seeing adaptation of this into other services. So special children's services is one that we're currently looking at, spreading this learning and taking the improvements to our working and how we're understanding what matters to people and putting it to another service as well. What we should also focus is on youth and young people. If you just move us on, I mentioned there, touched on some of the other work that's done. So our quality and human rights colleagues do discrete pieces of work as well. But they've got specific examples that we wanted to share here around focus groups that they did in partnership with Birth Companions, British Red Cross, and Roma workers in Greater Glasgow Clyde. And that was to dig in and understand a little bit more about the experiences of women and how that could then drive change and help trigger improvement projects, different ways of working, different ways of delivering information and care to women. So we very much started with a person-centred approach around our improvement activity to understand what matters. We have an idea of what we need to change and what we wanted to change, but we started very much with, let's go talk to the source and figure it out. And if we can we test some thinking at the same time? Very useful feedback, very useful to compare it to wider population and understand what that looks like. Some of the improvements for this, if you just move us to the next slide, led to more in-depth audits of our interpretive services, how we delivered interpretation care, interpretation support, and with that audit being repeated to look at measuring the key improvements and changes over time. Looked at changes to our leaflets and materials that we provide, how clear it is and easy it is to access translation support. Also a range of pieces of work through Tuesday Topics and targeted marketing through our maternity services to increase knowledge and awareness, which has seen like an increase in conversations involving interpretation services and improvements around, not to steal your thunder about the slides you're going to talk to, Mary, but improvements around how women are accessing maternity care and how they're planning their birth. Big thing has been videos and looking at different ways of providing content in different medium. And a big plan for this year is to look at how we start to plan videos and develop antenatal sessions or small little videos that just teach how to do things or teach people, provide little bits of context or little bits of short advice, and look at how we can do that in different languages, and how we, or through verbal different languages or through written different languages and different ways of providing that through subtitles. So that's a bit of a run through of some of the activity that we've been taking place in Greater Glasgow and Clyde. Like I say, it's been quite an excellent journey, and it's led to a lot of thinking for us as a public involvement team about how we can improve practice in other bits of the board and other projects. While that 2,800 responses was great, as I said, it's a lot of data, so we split it into two groups now. So it's now about 6,000 a time, twice a year, which is still quite a lot of information, but it's really rich, a lot of information in there, and we're looking at how we can improve who we send it out to get it out to more people in their own language as much as possible. One warning I would say is we added our care opinion link at the end of the survey. It triggered an awful lot of care opinions. We got about 40 extra in a month, which caused a little bit of scrambling because they were a slightly unexpected response rate to that. But again, still really rich information and a really good way of getting that extra, those more in-depth stories for women who maybe felt that those methods weren't quite right for them and they wanted another way to share their feedback. I'll just hand over to yourself, Mary, and
yeah, we'll move on to the next slide. Thanks, Paul. So I thought it would be helpful to just put some of that work that we've been doing in the context of kind of, so what impact is that having in the way that we're providing maternity services. So many of you will know that in the Best Start policy, some of the recommendations were about ensuring that women were able to have engaging conversations to plan their birth, the place of birth, how they wanted their labour and birth to be, really making informed decisions. So what we wanted to do is track to what extent women were able to engage in those conversations and co-produce their birth plans. When we first started looking at that in our Badgernet app, so that's our electronic maternity record, and women also have access to an app on their phones during their pregnancy journey that they can access. We had a look to see how many women were completing the co-produced birth plan, and you can see there that it was very low when we began to look at this. So it was 10% or lower for women. What we started to do through all of our work around Best Start implementation since 2022 is try and look through the lens of, and how does this impact on our lesser heard groups of women? So global majority women who are cared for by what we now call the Blossom team, which used to be called the SNPs team. So that's women with substance misuse issues, living with very significant deprivation. So looking through that lens at all the work we're doing to see how this impacts on them. I've also got to say that actually, in terms of lesser heard groups, I think sometimes maternity staff haven't really been listened to when there are big changes to maternity services. And that's something that we really wanted to do as well as part of this work. So when we were beginning to pick up on implementation of continuity of care again after the pandemic, we wanted to talk to midwives about, well, what would support you to provide more continuity of care and to have these discussions about birth plans. And the midwives were very clear that what they needed was longer appointments. And so we extended the booking appointment from 60 minutes to 90 minutes. And we've extended all return antenatal appointments from 20 minutes to half an hour. So providing that additional time has then begun to increase the amount of women that we're seeing, as you can see from these graphs with those positive upticks at the end, have been engaged in co-producing their birth plan. But you'll see there that when we started, Asian women and Black African women were much less likely than our white UK population to have those conversations and have that care plan documented. And you can see that just by really holding up a mirror to this, it's helped staff begin to think this is an important aspect of care for all women, and we need to make sure that we're using interpreting services. We're using third sector organisations like doulas and also AMA birth companions and Home Start to engage women in having those birth planning conversations. We'll go on to the next slide, please. Thank you. You'll have also heard, if you were at the webinar last summer, about the work that we've done looking at access of global majority women to our alongside midwife units, and how we sought to increase that, making sure that we were providing all of the midwives and maternity staff with cultural competency training. And we're now moving into a phase of providing all of our maternity staff with anti-racist training. What we've done here is in relation to continuity of carer. We have been tracking the extent to which women have continuity of care in the antenatal period in this graph. And you'll see that that top blue line is white UK women in our care. So they've consistently had higher levels of continuity of care compared to when you see the orange line, that's white non-GB women. The yellow line is Asian women. And then the two dark blue lines are Black African women and Arab women. So you'll see that consistently those women have had poorer experiences of care. And I think that's been really interesting for us, because we know the Embrace findings, which identify that women are much more likely to experience significant morbidity and mortality even during their pregnancy journey and have worse outcomes for their newborns. What's been really good for us as a service is to actually look underneath that headline data and to think, well, what is it that's actually going on for these women when they come through our services? How is their care being impacted? And so being able to look and see that they're actually having less continuity of carer has given us that real focus for our caseloading teams, in particular our Blossom team, who've now taken on a caseload model so that they're really able to focus that care and that continuity on the most deprived women and also on global majority women. So we'll just go on to what I think is going to be the final slide. If that's okay. Yeah. So thank you very much for listening, and we'd be happy to answer questions at the end after this next presentation. Thank you.
Thank you so much, Mary and Paul. That was absolutely wonderful. And I really love the fact that you were really honest at the beginning. You, as the director of midwifery, to go, we were really late to the party. I think that's really important, because it's just, we all feel the same. We've all been, it feels a bit like Arrested Development with the pandemic, where everything was suspended into critical circumstances and critical care pathways, etc. And then now we're stopping and looking back and thinking, actually, we've got so much to do. So I really appreciate that honesty and there's fantastic examples and lots of engagement and questions there. I've got a few myself for you at the end, but I'm going to steal myself and allow the next presentation, and then we'll allow questions from 11:25. So I'm very grateful to Donna, Frew and Claire McMorland for their presentation on the voices of care experienced children and young people and quality improvement. So Ayrshire and Arran has a place in my heart, as it's where I started my paediatric career. I moved from an adult ED job at the Glasgow Royal Infirmary and went into the old neonatal unit in Arran, and within 2 days just fell in love with paediatrics. And it shows how old I am, because that was 1997 and that unit doesn't exist anymore, but the Ayrshire and Arran team are fantastic. Donna is a paediatric nurse by trade, and having undertaken quality improvement work in her local board, is now moved up to being a senior improvement advisor in SPSP. So we've stolen her from the board for acute care, and we were grateful to have Claire McMorland, who's a clinical team leader for the South Ayrshire Children's Health Service, and has extensive experience with regards to all forms of paediatric services, but primarily around care experienced children and looking at school-aged children. So I'm really grateful to you both for your presentation. Thank you so much. Over to you.
Thank you, Sonia, and good morning, everyone. So as Sonia said, thank you so much for introducing us. Me and Claire have really teamed up together. So a bit of background: when I worked in South Ayrshire as a clinical team leader in the children's health team, I started a QI project, and it was really about how can we make processes safe for our care experienced children and young people. So as we tell you a wee bit more about that, at the implementation stage, after we've seen implementation of that QI project, I then got a new post, and that's when I moved to Healthcare Improvement Scotland. And thankfully Claire took that baton and continued that really hard work, and I want to hear more about that developing. So you'll hear that more during this presentation. Next slide, please. So background, so when I was looking at a QI project, this was when I undertook the NEST skill improvement course. Really every QI project has a background, so that's your reason why. So looking at significant adverse events, first of all, we noticed in NHS Ayrshire and Arran that children and young people who were being transitioned and supported really with that transition into a new care setting, there was occasions that were reported where children and young people didn't have their immediate health needs met. So we knew that had to be a priority. In line with NHS Ayrshire and Arran's values, we knew that process had to continue to be caring, safe and respectful. And as you'll see, we've highlighted the key priorities in the middle there, those really valuable kind of frameworks. Everything that we use has to be underpinned in that practice. So getting it right for every child, looking at our UN Convention of the Rights of the Child incorporation in Scotland, and the promise in Scotland. We're very fortunate in Ayrshire and Arran. We had good leadership support, not only from our children's health team in South Ayrshire when we started the project, but we do have a corporate parenting task force. So having that really there front and centre from the start, thinking about how we can create conditions for change, was really important. And we knew that we already had MDT working across social work, third sector, various agencies to support children and young people who are care experienced, but how can we strengthen them and include that in the improvement process? Next slide, please. So I'm going to hand over to Claire. I think it's when we spoke about this presentation, we kind of wanted to highlight what we already do in our roles. So how do we engage with children and young people in our roles? Claire will then explain that and the local context and pass back to myself, and I'll go through that QI journey with you today. Over to you, Claire.
Donna, good morning everyone, and thank you for allowing us to share this QI journey with you. So in terms of our role, Health Visiting Service focuses on providing a robust preventative framework for all children and families in Scotland up to the age of 5 years. I suppose building on this foundation and reflecting the evidence base, the refocused school nursing role will have continued focus on prevention, early intervention and support for the most vulnerable children over 5 years who have been identified at risk by the Health Visiting Services. The refocused role of a school nurse takes away from a universal service to a more targeted intervention, and the supports gained will be either via a request for assistance or a kind of referral process. Although the school nurse service concentrates primarily on 10 priority areas, one of the priority areas, as we're discussing at the moment, is in relation to care experienced children and young people. Both the health visit and the school nurses undertakes comprehensive care experienced children and young people health assessment and reviews this in line with the Scottish Government guidance and completes annual reviews for these children as best practice. All influenced children and young people's views are gathered through these assessments, which are GIRFEC based, normally within the family home. And we utilise tools such as Shinari, observed behaviours, and we utilise SDQs, which is strength and difficulty questionnaires. And the score from this would inform any interventions that are required for our children and young people. This gathers the voice of the infant, child and young person in line with both Article 12 of the Article 12, of the UNCRC, and also informs the child's plan moving forward. Specifically within South Ayrshire Council, South Ayrshire have a commitment to, have created a children and young people services plan from 2023 to 26, with a commitment to young carers, children and young people with care experience at our heart. And this is guided by our priorities, which are the promise, families included, healthy and people, and the voice, which fits nicely in with this webinar. From this, we hold children and young people's voice at the heart of our services, and by undertaking a rights-based approach to planning for maximum impact. So I'll hand you back to Donna. Next slide.
Thank you so much, Claire. So yeah, having that local context is really important. We need that locally in our services, and really this QI project is an example of how we really met not only the needs of our children and young people, but how do we actually align with local priorities and improvement. Next slide, please. So our QI journey. So we knew that we really had to get ideas around the table. We had to have a big team who represented the whole process and really get going with that improvement methodology and thinking about how we can generate change ideas that are going to have a big impact on our system. So with this presentation today, I've highlighted key stages of the improvement journey, but I've also included a thing called liberating structures, and thank you, Caitlin, I see you've popped that in the chat. And it was really a tool at that time that was quite new to me, but it really helped give everybody a voice within the project and make it a bit of fun, especially when we're involving children, young people. We want that to be interactive and give everybody that opportunity. Next slide, please. So starting off with creating conditions. So I knew as part of this project and leading it that I wanted to engage first of all with our children and young people, our corporate parents and our frontline staff. Now, as part of that, I kind of thought, what could I do? Questionnaires, Microsoft Forms, emails, have a meeting. But again, I wanted to have that interaction. So using a liberating structure called User Experience Fishbowl was really interesting. As a first kind of stage, I wanted to hear, first of all, for children and young people, what was your experience of that transition in care setting? What could have been better? What worked really, really well as well? I think that's really important to capture. And getting the same from our corporate parents and frontline staff, because quite often there's already change ideas there. We just need to kind of tease them out and join them together. So as you can see, some of our feedback from children and young people was sometimes it's hard to explain my health problems over and over. And that's something that we heard quite a lot about: repetition, new members of staff involved in a process, being supported to live in a new area as well. Staff need to know about my health to support me properly. So we knew that had to be a focus of this project. Next slide, please. So the project team, I think getting that first creating conditions step, getting to know what everybody felt and experienced was really important, and it informed that project team. So we had care experienced children and young people at the centre. I was the lead at the top there as a clinical team leader, and thinking about people who are really pivotal in that process, thinking about notifications, communication, knowledge and expertise. We had a rough idea who we needed in our team, and we had very grateful volunteers who participated in this project, firstly in South Ayrshire. Next slide, please. So then understanding systems. So we had the right people in there. How could we understand the systems that are at play? We had some worries quite at the start, thinking, oh no, is this going to be another new process we need to add? Because we knew staff were stretched, but equally they wanted to make a difference and they wanted to improve how that service delivered for children and young people. So understanding systems was really important. And I think one of the strengths that I would share was having the child or young person's journey at the very centre of that. So we basically mapped out in person what was a child or young person's journey. At the top, we had a social work process. At the bottom, we had a health process. And really, there was a lot of crossover points, but it was quite disconnected, we noticed. So we've seen areas for improvement there that we could feed into and join at a much earlier stage of notification and sharing that vital health information. One of the liberating structures we used in this point was celebrity interview, and it sounded quite interesting and quite engaging. It was really fun. And really some of the questions that our children and young people wanted to ask was, what's your job? So I know your title, but what do you actually do? And what can you do to support children and young people who are care experienced? That then let us share our roles, responsibilities, what connections we had in the system as well, and where we could leverage change. Next slide, please. So developing aims, this allowed us then that understanding of what's in a system, what do we need to make change and have those change ideas happen into fruition and making a developed aim. We formed a driver diagram. So this was our very first draft of our driver diagram. So we knew that we had to be mindful of capacity, effective communication, but we had to make those processes child-centred. And really thinking what change idea could we start with. So again, gathering the views of children and young people and corporate parents, we thought, you know, what are they saying at this point? So it would have been even better if the staff had all my information before my move. It would be good to know if something happens, staff and carers know how to help me, because I think we forget this is a really vulnerable time for children and young people. We're transitioning them into a safe environment, but for them, it's something new, it's something unknown. So we felt at that point, from all the change ideas we had, and we had a few more, that how could we try a health safety check phone line so that we don't need to wait on standard notification to a health visitor or a health professional after the move has happened? How can we do that as early intervention and prevention of anything happening that's harmful at that stage? So that's what we chose to focus on. On the next slide, if we move on. This was a snapshot of one section of our health safety check. So the goal of that really was to provide rapid and timely review of health databases. As you will all probably relate to, there were about 4 or 5 databases that had to be searched, and not everybody had access to each one. We really wanted to highlight health concerns needing action in that immediate time frame. So as a starting point, starting small and quality improvement, there was a small team of myself, and we had public health nurses who helped us. And at any point during office hours, they could, staff members could call and say, we're thinking this may be a point that we need to transition a child or young person to a new care setting. Could you do this check, please, before we do that? So we're seeing earlier interventions coming in, and we would scan all the systems and we would email that back out to a secure mailbox and social work, but we would also include, the child's named health visitor, specialist nurse. We would let them know this has been done as a kind of measure of safety at this time, and that really promoted that notification process a lot sooner, giving people the heads up that this might be an outcome for the child or young person, keeping everyone involved who is surrounded round about that child and young person's team. Next slide, please. Then data and measurement. So we thought, right, we've got our change idea, we understand our systems, we've got a process in place. How do we measure if this is working or not? So our outcome measure was we had to keep an eye on the number of children whose immediate health needs were met at point of transition. So we could measure that easily. That was in our paperwork, and thanks to process mapping, we could do that at an earlier stage, and we were able to track that data really usefully. But one thing I felt was really important was to show process measures as well, because we need that family of measures round about a QI project. So this was really the time taken for that health safety check completion. So from the first point where we get a phone call to say, could you please provide this information, to the last point of secure mailbox notification and return phone call to the requesting staff member who required that information. So as you can see, we started the health safety check at one point, and we did see quite an immediate drop in the amount of time it took. Rather than contacting multiple people for multiple pieces of information, one person who took that call could check all databases and really returned it quite quickly. We then needed a systems training update. There was a few changes in a couple of systems, and some that personally I wasn't familiar with. So I was really fortunate to have, and they really should have been named as part of our team, but it was where eHealth colleagues were vital in this. They provided really focused training for us, and it improved our systems and accessing that data. We did have one IT issue, but I'm sure that's to be expected. We did have a longer time back returning that phone call and that information, but it certainly wasn't at our start, which was good. And then we've seen that kind of settle down and sustain as we move forward. And in South Ayrshire, it really was a good system that was working. And we took the opportunity then to use this process measure to reassure other people within the system that, look, it doesn't take long. It's one phone call. Your phone call will literally take 5 minutes, if that. Give us a phone if you want this information early. Let's pull it all together and get it ready. So that really helped us get support in place to really spread it across South Ayrshire. If you click next, Elaine. So how did we go about implementing? If we click again, sorry, I've got a couple of wee animations. So rightfully so, Children and Young People says, how can you make sure everyone knows about this health safety check? What can you do to make sure everybody knows about it? It's not just one wee team. How can you spread it first of all in South Ayrshire and implement it? And again, the next wee animation, Elaine, is another liberating structure. And I'm sure lots of people were probably sick of hearing about them, but as time went on, they really appreciated them. So thinking really with this one, it was about what can we do? What's the 15% we have that we can do in our roles to spread, so it wasn't just person dependent. Let's spread the word about this system. It was a really good liberating structure because it kept the momentum going. Next slide, please. So outcomes. So the health safety check did provide that process of a single responsive point for contact for social workers to gather that critical health information, and it really helped reduce risk and support transition for children and young people. Our outcome measure, 86% of children and young people had their immediate healthcare needs met when they were newly accommodated or had a change of placement. So that did exceed our initial aim of 70%, which was great. Next slide, please. Some of the feedback we got looking throughout the process and sharing that with the people that we engaged with at the start. Children and young people commented, this makes sure no one will forget the important stuff about my allergies or medicine, and helps other children and young people. It made them feel safe and included. And from our parenting task force, they fed back that it was breaking through information sharing barriers to provide accurate health information in that responsive and safe manner. So we knew it worked in South Ayrshire, and again at that point, that's when I got my post in Healthcare Improvement Scotland, and I handed that baton on to Claire. So if we move on to the next slide, Claire's going to fill you in just a wee bit about that scale and spread and how did we make it sustainable within North Ayrshire from a tiny QI project and scale it across the system. I'll pass over to you, Claire.
Donna. So within South Ayrshire, myself and my colleague continued to field over the health safety check calls, and we would access all the health systems and carry out the health safety checks. And as part of the corporate parent task force, we looked at actually can we sustain this out with the periods of 9 to 5. Myself and my colleague worked between the hours of 9 to 5, Monday to Friday. And as we all know, a lot of children move homes, at weekends and emergency placements. Therefore, we had to think outside the box as to how we could take this great piece of work but actually roll it out so that it was a 24/7 available to all children and young people. So as part of the corporate parent task force, we looked at that and we actually thought, well, there is Ward 1A within Crosshouse Hospital would be able to take that role on. We discussed it with paediatricians. This was an ongoing piece of work through the corporate parent task force, and we rolled it out to look to do a small test of change really round about that, and it was successful. And from that piece of work, we have looked at rolling that out pan-Ayrshire. So the health safety check has now went from being a South Ayrshire kind of one-man piece of work to actually rolled out pan-Ayrshire, that any social worker can contact that one point of contact and get that relevant information in a timeous manner for all children and young people. And I suppose continue to be crucial in providing the right care at the right time by the right service in line with GARFEC for our families within South Ayrshire.
Thank you, Claire. And our next slide is just a thank you. Thank you for giving us the opportunity to talk about this today, and certainly putting my old hat on was interesting, but it's lovely to see how that work has spread from a tiny QI project across Ayrshire and still have an impact in improving safety and reliability of care for children and young people who are care experienced. Thank you.
Thank you so much to both of you, and I think both the presentations demonstrate what happens with a positive intention and a commitment for progress. Even if you're starting from different areas and different views, it's that kind of intentionality, and actually we know this is the right thing to do, so what can you do, what can I do, and working together. I also want to thank both sets of speakers for fantastically engaging slides. I love the pictures. It's brilliant, and it's really great way of giving us a snapshot of information quickly and visually. So that's really appreciated from everyone in the audience. And I also want to, the final thing before we move to questions, is that in 20 minutes I counted 8 different individuals inviting others to email them to learn about projects and work that they're doing, and a minimum of 12 resources that have been shared, and policy documents and frameworks and ideas and things. So that's fantastic, everyone. Thank you so much for the level of engagement and ideas. And particularly the work that Donna started and Claire has progressed. It demonstrates what happens with a small seed of a project, and if you follow through on the same quality improvement throughs, how you can progress it, improve systems, improve that patient-centred approach, and then scale it with intention across the whole systems. That's fantastic. It's now over to all of you for questions and answers and discussion. So I'm going to go to Tim, who's been monitoring the chat first of all. Thank you to all our speakers. You can feel free to have a drink of water whilst Tim's just gathering some questions for you. And then over to you, Tim.
Thanks, Sonia. I'll just encourage everybody to continue popping questions in the chat or raise your hand as well. So far, Sonia, we only have one question from the chat which still needs answered, because there were a couple in there about resources and things which have gone on to be answered. But the first question I want to come to is from Laura Brown, and it was just asking Paul, could you say more about how you use the preferred languages recorded on BadgerNet to reach out by text or digitally to women who in their preferred languages, please?
Yeah, totally. So as part of our work to reach out using digital means, BadgerNet offers a chance to draw down phone numbers and email addresses, but it also provides the opportunity to look at the language selected by women on there as the preferred choice. So we can use that to do a bit of a count and understand the makeup of the women who've used BadgerNet or logged on. Now, that's not a complete picture necessarily. So what we do is also have a bit of a conversation with our public health colleagues who do a bit of a running count over a number of years to average out languages and such, but it just gives us a couple of points of reference to look at and understand different language support needs that might be out there. So it's been really useful just to leverage some of the data behind that system and to better understand it and marry it with that wider conversation with public health colleagues in GGC.
Paul, can I ask you a silly question? But who puts it? So as a paediatrician, I wouldn't know about the element of putting the information onto BadgerNet. So is it the midwife at the first booking appointment that does that, or is it health record staff that would do that onto BadgerNet for your preferred language?
I can't remember exactly how BadgerNet works. Mary, would you know better? I believe there's a self thing.
Okay.
Sign up now for BadgerNet, so I believe it'll be self-selected at this point of registering the pregnancy. Great. Mary's nodding, so I'm glad I got that right.
Full marks you've passed.
Yeah, Laura, sorry, that would make sense for me to talk about that part. So when we get the survey translated, we also get a text and an email translated as well. So we identify the language preferred, but we give options for when they click through. So even if somebody requests it has put their language as English, but they prefer to, when they get it, the email and message wouldn't be in English, but they would have the option to pick a different language from the actual survey themselves. So occasionally we might get somebody who their preferred language isn't correctly recorded by themselves, or they put English, but actually they'd be a little bit more comfortable in a different language. So they'll receive the invite in English, but when they click through, they'll get a list of options and they can pick their own language from that if it's present. And we encourage people to get in touch if they need a bit of support as well around about this for any additional language supports where we can. We're limited somewhat on the volume of languages that we can translate, partly just by the systems, what languages they support, and how many we can comfortably add to a form before it becomes unwieldy to use. So that's a balancing point. And we're looking at different ways to engage with communities that we might not reach via digital, which we would do anyway, because digital's not universal necessarily, but we shouldn't disregard it. What we've learned is, digital shouldn't be disregarded for reaching traditionally difficult to reach groups or groups where we don't share language with. It's another tool, but it doesn't replace the importance of that community conversation as well. But it's not to be discounted.
I think that's a very point well made, Paul. Is there a question, Marianne? I see you've got your camera on. Would you like to ask a question?
So you were just saying at the beginning, Sonia, how you'd really like more time to listen to the children in your care. And I think it's a really important part of patient-centred care that we just don't have the resources or time to do. And for groups that are harder to hear, we need more resources. I just wondered if there's examples of where you'd get resources from, or is there good ideas that people have had that help clinical staff do this?
Thank you.
Sonia, I'll come back in with another question from the chat, and it was just a question for Donna and Claire as to whether newborn babies were included in this project where the health check calls were made, and was that population heard?
Yeah, absolutely. Sometimes we would actually get calls in the antenatal period as well, and we would immediately link with the named midwife and any kind of key staff, because we're very conscious. I think pulling information is one thing, but you need to have everybody involved in that process at that time. You don't want that to replace getting in touch with the named midwife and named professionals at that point. So no, absolutely, yeah. The only thing that I think that one of the exclusions we had was children from out of area, so out of Ayrshire. We didn't always have access to their health records, but certainly when it came to age range within Ayrshire, we could provide that, Marianne. Yep.
That's really helpful, thank you. Just going back to Marianne's question, any advice or top tips on thinking about the time required? Certainly, Mary, in your presentation, you mentioned that actually that's a change that you made. I imagine it's easier for the director of midwifery to make a change. We would hope, but it'd be helpful to hear for the frontline teams what you would suggest as approaches.
Yeah, no, it has been really helpful, but it has also been really challenging. So because when you lengthen appointments, it then has a really big impact on clinic times and the amount of clinic space that you need. So it actually has really big repercussions. So I might just say, I'm going to wave a wand and everyone's going to have longer appointments. But then actually there's an awful lot of work that then needs to be done to make sure that we have that clinic space. And we're still seeking to access different GP surgeries, health and social care partnership buildings that midwives stepped back from over 10 years ago, that we're now saying, please, can you let us back in? So it's not without its challenges. And in one of our areas, we haven't been able to increase bookings yet to the full 90 minutes. We're sitting at 75. So it's still a work in progress.
That's great. Thank you. Anyone else want to make a comment on the time aspect? I think it's genuinely from a kind of paediatrics point of view. I think what we've tried to do is get medical students to help us with projects to process map, because everyone has a sense of the problem, but frequently you don't actually have enough time to sit together and go, well, I think it's a tail, and I think it's a trunk, and actually it's the whole thing's an elephant. So actually having medical students with our QI advisor to map out the young person's experience has been really helpful. And then because they've then dedicated that time and been supported by our improvement advisor to then use that focused meeting with the healthcare team to then think, okay, now what we're going to try, and then go through the operational line. And we haven't gone straight in with all the clinics need more time, because actually the first responses will prove to me that it does. But by sort of using a project approach and using individuals who have time compared to frontline staff and who have an appetite for improvement and want to help and want to learn, that's been very powerful using the students. Paul?
It was just to reinforce that point a little bit. It's been a really valuable tool in other services that I've worked with, of working with students, trainees, to perhaps carry out short targeted QI projects, but really the bit that they really get involved in quite a lot, and it adds a lot of value, is we might do this big piece where we're reaching out to a lot of people, but having those trainees, those students there to be able to maybe do a couple of interviews, 5, 6, not a massive amount, but to understand the more in-depth experiences is really valuable. And it's really good to see from a public involvement point of view, because it's getting that ethos of involvement front and centre amongst new staff who are coming in very early, and it leads to quite good outcomes generally. I've got a couple of projects where we're looking at doing it at the moment, but it's generally been well received, and it has led to some more in-depth and more interesting work where wouldn't have capacity to necessarily do it to the level that they do, but can offer them a bit of guidance and support.
That's fantastic. Helen, I can thank you so much for that. That's really helpful. Helen, I can see that your camera is now working and your mic is hopefully on. Would you like to ask a question of the group?
I know, I felt really disabled. Imagine me not being able to talk.
You've been on the naughty list, Helen.
Imagine that. I've obviously been the naughty step. A couple of things that was difficult to type, and it was just, I wondered, Donna, I sat up and took notice when you said things like, when you talked about care experienced children about repeating, feel as if they're repeating themselves. Now, I've been doing this job for a long time and listen to parents say that all the time. So I wondered, in the work you were doing, is there something you can think about moving on to be transferable for? Because again, you've included acute. I know you did it in a sort of, and you've included acute, which is great, but something that we could maybe be, you started that work, moving that on to say, how can we maybe, for our very complex children, look and see how we can get things better at not having people repeating themselves and families feeling as if they should have a wee tape deck with them all the time. I wondered if that had been discussed. It was just hard to put in my chat. I couldn't put all that down.
No, absolutely, Helen. And yeah, that comes through loud and clear from a lot of people and more children and young people. And I think it's always that fear of, I'm going to forget something, or where do I start, in that situation. One of the really useful change ideas that came out, not only the kind of health safety check, was about having a kind of patient held record or some kind of information that they can say, this is my story. Like young children, young people are really keen to hear that from their point of view and their language as well. Claire, feel free to pop in as well, but I think you're absolutely right. How do we look at that and think about the communication and that person-centred care as well?
I think just as part of the bigger picture with the Corporate Parent Task Force that I currently sit on, we're looking at the notification process of children becoming care experienced and actually how we share that information, what information we share, so that it is only that one piece being shared at one time for that child's journey. Again, it's starting from, a place of, as Donna said, from nothing to working our way up, but we are very much focused on that.
Thank you.
In the chat, I think it's really useful. Peter's mentioned, what matters to me, absolutely, and patient passport. And again, we've got all these things that already exist, and I think that was part of the learning. What already is out there? What are we doing just now? So we're not doing something totally different in South Ayrshire to everywhere else in Ayrshire, and other services as well. So it's a kind of ongoing piece of work, I'm sure, in every service, that how can we reduce that repetition and improve the communication and information that we capture at that time.
Yeah, and what matters to me is great, provided people, one, ask the question, listen to it, and actually provide an outcome about what really does matter, and we act on it. I think it's great, but I think sometimes it can be tokenistic. That's super. Thanks very much.
As part of our health assessments that we complete both for pre-5 and school-age children, it is about gathering that voice of that child, which is fundamental, and that informs any interventions or actions or further referrals that we need to do for that child.
And I'm thinking as well, Claire, like some of the examples, we had one young person, when we asked, what matters to you, collecting all this health information with multiple medications, allergies and different things, what matters to you? She's like, I really don't want to miss brownies on a Wednesday night. Let's see all that stuff. That should go in the background, but that's what matters to me when you're moving me from one area to another. And I'm like, absolutely. So that's what matters to you. We will include that in there. So it opened up loads of different ways that we could think about it, Helen. Absolutely.
Good, thank you. And Sonia, see, the other thing we've started doing, we've noticed a rise is we put the QR code for care opinion, and remember there's now a part of care opinion for children. It's a bear, and we've put that onto our discharge paperwork. And it's too early to tell yet, but perhaps a rise of people using care opinion to seek opinion about what their care has been like, good or bad, is coming in. It seems to be increasing a wee bit, so we found that to be useful.
That's interesting. Yeah, thank you. That's really helpful. Claire, did you have your hand up?
It was just to say, yeah, we're currently looking at care opinion for young people. We have it for adult services, so we're looking at that for young people. But up to this point, what we've done is we've created a QR code for all children and young people that where we carry out any intervention with, they provide us with the feedback as to what we've done well, what we could do better, and what it means to them.
Mm-hmm. Thank you, Claire. And there's a comment from Paul Hayes saying, could you share a copy of the discharge paperwork with the bear on it? That would be great, actually, because you guys use Track, don't you? So do they get it'd be useful to know if you have an additional leaflet that gets handed out, or is it actually printed out on the Track summary?
No, it's I don't think it's on the Track summary, Sonia. I think it's what we hand out when we leave the ward, but I'll get it for you and I'll get it sent. If I do it, Paul, send me your email address, will you?
Yeah, that's fantastic.
Thank you.
Tim?
Thanks, Sonia. I was just going to bring in another question that popped up in the chat a little bit earlier, and it was from Rebecca Drummond, and it's just a question. It's a question about whether or not there's a text translation device that other people are using for text reminders. So I thought I'd pop that out there too.
For everything we do around translation, it's through our public health and translation team, because it's a national policy still not to use machine learning or AI translation at the moment, although I believe that's to be reviewed in the next year or so. Maybe this, I can't remember what year the review was due. So, but there would be nothing against getting properly translated common phrases. That would make sense as a commonality between services in theory. Just have to agree a translation team to do it and then do it, split the cost. But yeah, we don't use any machine learning at the moment.
Thanks very much. Sonia, that's all the questions from the chat. I will say there was an issue with some mics and cameras not being disabled previously. Everybody, I think, should now have their mics and cameras enabled. So please feel free to raise your hands if there's any further questions from the speakers. Otherwise, I'll pass back over to you, Sonia.
Thank you. I'm conscious of the time, but I have two questions for the group, of presenters. One is a bit more higher level, and the other one is a bit more directive. So I guess the first one was in order. I'm going to use chair's privilege here, but I guess you've all described ways of partnership working and engaging with your communities that you care for. But in order to have that, you have to have trust. And certainly some of the families that I've seen in the past, they've said there's a sense of anxiety around, if I share this information, what are you going to do with it? Especially our families who have from conflict zones or refugees or who are escaping other forms of trauma, and there is a willingness and a need to share, because there is a recognition that our teams can help, but there's also a real sense of concern because of previous experiences. And so how have you managed to just take that initial step to establish trust? Any comments on that? Thank you. Mary?
I think one of the ways that we've done that is actually building up our relationships with some of the third sector organisations that work with women in these situations. So in particular, AMA Birth Companions. I meet with them every other month, and they are also members of our third sector network group. And that's meant that we have really open and honest conversations about what they have witnessed and the experiences of care of the women that they support. And certainly what I found is that often women in their care don't want to put in formal complaints, don't want to have their name on complaints. And so AMA will share with us a vignette of a story, and then we'll feed that back to staff, not necessarily with a name. So I think that's been an important element, so that we're protecting women's desire not to be named necessarily in a complaint. The other way that we've built trust is through outreach workers into a number of different community groups through our equalities team, and the British Red Cross, and so we have peer support workers who are involved in those groups, and then who also attend the third sector network, but also now our maternity communication group, so that they can really help us shape communication with different groups of women in our care. I think the other key element is around really building in continuity of carer by midwives through the journey, so that these families build that trust with the service through the pregnancy. And certainly we've seen a huge impact of providing the Blossom team, so previously the SNPs team, with much smaller caseloads, longer appointments, and holding a caseload, and so really building up that trust between maternity services and those families.
That's fantastic, Mary. Thank you for those examples. Donna?
Thanks, Sonia. I think reflecting back to the beginning of the QI project that we spoke about, I think having that consultation at the start and creating conditions for change was really important. I think with processes as they were at that time, there was always room for improvement, but how we did it was quite vital. And it was that safe communication, you know, between our teams, but equally keeping children and young people involved throughout the process was really vital. So they weren't kind of used as a one-stop survey shop and just to do a bit of work and put it in paper. It was meaningful engagement that we were doing and kind of demonstrating that change, not only to children and young people, but to the likes of our task force and senior leadership, and sharing stories of, because we didn't just get social workers phoning us, we ended up getting, you know, third sector and different things. Can we phone you for this information? And we can do that. We're best placed to do that at this time. And more people were getting involved and kind of buy in from that process. So I think seeing it from start to implementation was really good, and keeping that safe communication in place was vital, Sonia.
Fantastic. Thank you, Donna. Laura, thanks for switching on your camera. Do you mind introducing yourself and then asking your question? Thank you.
Hello, I'm Laura Brown. I'm Programme Manager for the Scottish Perinatal Network. And I just put my hand up to follow on a little bit from what Mary said there about the role of advocacy for including the voices of women and families. I guess through our work on the Scottish Maternity Engagement Framework I linked into the chat earlier, one of the things that came through was the need to consider the context of people's circumstances at the time, when absolutely we want to engage with people, we want to hear from them, we want to include people's voices. However, in context of, as Mary mentioned, if they maybe come from traumatic circumstances, perhaps in this country with insecure housing, insecure finance, very complex socioeconomic circumstances, that sometimes those people might not be best placed to advocate for their own views at that particular point in time. But there is a role there for engaging with the third sector partners who are maybe providing support in other ways to the same people, and to include those views through advocacy approaches as well, and in parallel as a supportive mechanism for making sure that they are included. Thank you.
That's really helpful, Laura. Thank you so much. I just have one. I'm aware we've got 2 minutes, and there was a comment from Matilda in the chat earlier on around how it was hard to just build back on and connect to some of the themes of what the teams have discussed here. But she had said it was hard to get data-driven change when you have a small population for ethnic minorities in her caseload. And certainly as a CD, what I found is even if you have fantastic pieces of work, when you're then trying to get that final part of getting long-term funding, and once you've changed pathways and you know it works, if when you're then searching for long-term funding, the biggest question that comes back is give me your numbers, give me the cost. And actually, unless there's a real terms financial saving, we've certainly had a couple of major projects that improved the care of children and preventative care of children. discontinued in terms of long-term funding because it was project funding and they couldn't find long-term funding, although there was full recognition from the board that it was excellent pieces of work. So what advice do you have for the teams out there who may have a small population, but as you've all shown us, is an important population that have a greater need for that patient and person-centred approach, because actually the long-term gains for that individual and for their the people that they come into contact to in their future lives is exponentially positive if you engage at the right time. Mary?
Yeah, I don't think I'd necessarily, want to give advice to really experienced people in this field, but what certainly we felt in GGC is that if we didn't do this work, then how could we expect any other boards in Scotland to lead on this work, because we do have the most diverse population, and so we felt that it was really incumbent on us to lead on things. I think even though we have that very high proportion of our maternity service users who are global majority women, it hasn't actually always been easy for us to access additional funding to improve that work. I'm very keen for us, for example, to have a cultural safety midwife role that they have in a number of trusts down south in Bolton and Bradford that could really lead on some innovative work in our board area. So we've reached out to Bolton and Bradford. We've got job descriptions. We're ready to go if we're able to identify funding for that. So it's not always simple but I think it's vital that you're a bit imaginative and try and see whether there are additional streams of funding from things like endowment funds or charitable funding for temporary project roles. We've certainly found putting in midwives in temporary project roles for a number of different pieces of work just really exponentially increases the rate of change. So we've really valued those in terms of improving care.
That's fantastic, and certainly there's lots of examples in the literature and in different boards around. Actually, it doesn't have to be about large numbers. The power of the story in itself, is meaningful. And if one patient has a bad experience, then that's just the tip of the iceberg, isn't it? So there's a lot that you can do with that. Helen, I think you made a comment. Would you like to come in?
Yeah. One of the ways we've done it, and it doesn't happen very often. It's difficult, and you've got to the right families feeling and patients feeling happy to do it, is that patient story is so powerful, and in actual fact getting to the board. So the board having a slot where there's a patient story heard, good or bad, and if you can get the right person in that slot, it's almost like people realise, because that measuring, if you get small numbers, that measuring of the value is to that family. And we've all got services that actually, when you look at it in paper, people will say, oh yeah, that's a massive resource, we need to make a cost saving. But when you look at what the impact could be and the impact of the family and the ongoing impact, for instance, community care as opposed to ending up in hospital, the community care stopped. If you get that patient story, and it's really powerful. It's a bit like, I relate it to a bit like, remember when we started patient safety and we always had patient stories at the very beginning, how powerful they were, where sometimes that voice being held at the board, even one person can make a difference, and people sit up and think, oh, that's really, impacted in that family, and therefore why wouldn't we carry that on? So when you've got really small numbers, sometimes that's effective, is another way of looking at it.
Absolutely. And certainly from my experience of engaging senior leaders, actually, most of them have, they've all got life experience. Most of them have children, grandchildren, daughters, or in-laws that are expecting a baby. So they're very passionate about the care of people. And it's just that sometimes they also don't want lots and lots of spreadsheets. They actually want the human story as well. And I think that's a fantastic example from Mercedes. Thank you. About patient story at healthcare governance. It sounds like that's not unique. And thanks very much for the link. I'm conscious of time. Thank you so much for everyone for their contributions, questions, lots of ideas, lots of networking and advice for all of us there. So I'm just going to draw the discussion section to a close. I will get towards our closing remarks. Next slide, Elaine, if you can. Thank you. So I mentioned some of the different webinars and things that we've had, and there's links to it in the chat. There you can see the list of all the different webinars that we've had around person-centred care, looking at racialised health inequalities, worry and concern, focusing on parent and patient concerns, lots of helpful reports, frameworks, toolkits. That's all on our website, and you can see the links there in the chat. And there was a particularly excellent perinatal and paediatric programme national learning session in October, which I certainly learnt a lot from. And again, all the resources and learning is there, open source for all your colleagues to share and to discuss. Next slide. So lots of, even though we've been very busy, we have lots more to come. So the SPSP Perinatal and Paediatric Programme National Learning Session has got online registration, and it's open to anyone working in perinatal or paediatric services. And there's also in-person registration, which is coordinated through the health boards. I know that the in-person places, even though it's coordinated through the health boards, I have had colleagues say, you know, how can we share this with more people? But certainly over the last few sessions, we've definitely tried to make the online access equivalent to and as interactive and interesting as those in person. So please, if you can't make it to the session in person, please register online. There's also an excellent session planned on the 11th of February for improving maternity care for global majority women. And then we've got further webinar on the 26th of February on Down syndrome in Scotland for the midwifery group there. And then maternity trauma informed awareness session on the 27th of February. So 3 sessions in February that are open source and free to teams to register. And a plea for you all to put a note in your diaries for that 23rd of April session. And please feel free to register online and signpost this session to as many of your teams that can attend. Next slide. I want to thank you all for being so engaged, taking the time out on a Monday morning, which is frequently a difficult time. I'd also like to thank all the speakers that have presented today. Thoroughly engaging, very meaningful and poignant work, and it demonstrates what can happen with just positive intention and the pursuit of progress. None of us are doing this perfectly, but together I get a sense that we're much stronger than we think we are, especially on a gloomy Monday when you can't see the sun. You've brought a ray of sunshine to us all. I'd really appreciate if people could click on the link or scan the QR code to give us some feedback. It's really important to us. The team at the SPSP are fantastic at listening to the feedback, considering ways to improve, any ideas or work that you want to share through the different Teams channels that we have for the improvement work. Please engage with those channels, put links in. And I love the fact that so many of you have been saying email me and uploading resources, etc. It's really fantastic. And I think Scotland as a nation is the perfect size to encourage this sort of network and learning from each other, and actually many colleagues who've worked elsewhere, Mary gave an excellent example there of reaching out to other PCTs down south to hear about job descriptions. So we're not alone in this work. We're very committed to this work, and it's fantastic to have this. I can see there's extra things in the chat there for the Chaz team. And then I think we've got 2 minutes left. So Tim, is it okay if I move on to the thank you slide, or do you want me to keep this up for a bit longer? There we go, the keeping in touch. So as I said at the beginning, we've got a very active team in our project management team who you saw there. Please email the email address there and you'll get a response from colleagues, and we'll try and connect you to different people. Please join our Teams channels for the different improvement work and start posting your ideas and sharing information. It's there for you. It's a closed team channel for everyone involved in the improvement work across our perinatal and paediatric programs. And again, we've got the web link there. So I just once again want to thank you all. It's a very busy Monday for everyone, and it's impressive that we reached a maximum of 82 people. So fantastic speakers, great work, and thank you very much.